Okay, I think we're going to go ahead and get started. Good morning, everybody. Thank you so much for joining us. Our numbers look much better than they did yesterday. As you know, we had some technical issues, and so I'll address those in a moment. But first of all, I wanted to say welcome to everybody. Thank you so much for joining us. My name is Michael Valere. I'm President and CEO of the Institute for Healthcare Advancement. Welcome to our 19th annual Health Literacy Conference, Health Equity and Disparities in the Time of COVID-19. I actually had a full welcome and overview in our session yesterday, and I know unfortunately many of you were not able to join that. Diana Pena Gonzalez is going to be joining you in just a moment and talk to you about how you can view that session for yesterday. But for now, I just wanted to say hello, welcome, thank you for being here. And I'm sorry about the technical issues. The server crashed, of course, first morning, as luck would have it. And there was some setting on some of the rooms that really did not allow people to join. Those things have been fixed. So hopefully you will have a good, positive experience today. And again, I am very thankful and happy that you are here to join us. And I hope you enjoy the rest of the conference. And please make sure you go back and watch those sessions from yesterday. I'm going to stop talking and I'm going to turn it over to your first host, Diana Gonzalez with the Institute for Healthcare Advancement. Diana?
Thanks, Michael. So everyone, my name is Diana Pena Gonzalez, and I am the Health Education Specialist at the Institute for Healthcare Advancement. And so before we get started, I just wanted to run through some of that housekeeping stuff that Michael mentioned. So to find those recordings from yesterday's plenary and breakout sessions, you can visit the website hlc.ihaforhealth.org. Again, it's hlc.ihaforhealth.org. And we can send that out to everyone, that website, so you can find it. It's also where you went to register for the conference. So that was our conference website where we had all the speaker bios and everything before this platform opened up. So we posted everything there for you for the recordings. And so moving forward, the recordings from today and the rest of this week, we're going to pack those up for you and get those ready. And those will be available before August 3rd. So again, all the recordings from yesterday are currently live and available to you at hlc.ihaforhealth.org. But then all the recordings from today and the remainder of the week will be available before August 3rd. If you're looking for presenter slides, you can find all the speaker slides on the sessions page under the tab Handouts. And then all attendees will be muted and audio will remain off and for the entire session. So if you have any questions, please use the Q&A box and we will hold all questions for this session today until all panelists have completed their presentations. For other questions, if you have any IT related issues, please email support@limitlessasr.org. And if you have any questions related to the conference, you can email us at conference@ihaforhealth.org and conference@iha4health.org. These emails, if you're looking for them, are easily found on the homepage. You just click, they're just a click away for you. If you're looking for CEUs, there are two surveys we need you to fill out. The first one is the session evaluation, and that's going to pop up for you after every session. Every session that you see, there'll be a session evaluation that pops up. And then there's also the overall conference evaluation, and that will be sent out to you automatically when the conference is over on Friday. So be on the lookout for that one because that one's really important for your CEUs. So once you get that, the overall conference evaluation, fill out that survey. At the very end, there's going to be a CEU request form. Click on that link, fill out the form, and send that over to us. We must get your overall conference evaluation and your CEU request form in order for us to successfully give you your credits for this week. Besides that, we'd like to share with you some poster presenters and awards that we have for you. We're excited to share 15 virtual posters, and some poster presenters even sent in some videos to share with you their thoughts and insights about their projects. And you can find those posters by going to the poster tab that you can find on the homepage. For the first time this year, we've also included a poster competition. And these posters were judged by depth of content, knowledge, organization, and poster design. In addition, every year IHA recognizes outstanding achievements in health literacy in 4 categories: international, innovative programs, published materials, and research. And to find out more about these projects and the winners of the awards and the posters, you can go back to the homepage and click on that link, and it'll direct you to find out more about our winners. For today's plenary, next slide, thanks, Mario. For today's plenary, we will elevate stories about individuals from communities with long-standing health disparities and illustrate how the pandemic has magnified their challenges. Due to time, we can only highlight a few communities, but we understand that there are many communities who deserve to be spotlighted. There are additional populations or topics that you feel need to be part of the discussion. Please submit those ideas in the plenary session work group in the engagement tab. Throughout the week, we are collecting these ideas to present overall findings on Friday and continue collaborating after the conference is over. So because of technical difficulties that we experienced yesterday, we encourage you to go and watch the videos that were recorded on Monday and submit your ideas and thoughts that you have for that in the conference work group, in the conference session, the plenary session survey that's found on the engagement tab. And yesterday's survey will be open for 24 hours. So please go to the hlc.iha4health.org, watch the video from yesterday, and submit all your thoughts and ideas on this engagement tab in the survey. So that way we can collect those ideas and report back to you guys. And that really the idea is so that we can continue moving some of these things forward and continue the work in the coming weeks. So together we can address these very difficult times and the populations that are most affected. Everyone says it one way or another. These have been some trying times, a threefold whirlwind: pandemic, economic hardships, and social injustice. Today, we're going to start the discussion to illuminate some of these issues and hope you can contribute to the conversation in the plenary work group survey. Next slide, please. It is my pleasure to introduce the moderator for the panel, Stan Hudson. Stan is the Health Literacy Director for Wisconsin Literacy, Inc. He is a health literacy expert and health policy analyst with 21 years of experience in health services research and 15 years of experience in health literacy with a focus on curriculum development. He earned an MA in sociology from the University of Missouri with a focus on race, class, and gender inequalities. Over the last decade, he has led the development and implementation of health literacy and health justice education programs and curricula for health systems and the communities they serve. I will now turn it over to you, Stan Hudson.
All right, well, thank you, Diana. And first off, I want to thank IHA for having this wonderful conference and this focus within COVID. I think it's so important, you know, as everyone knows and has seen, COVID has only brought to light the issues and inequalities that we've already had from early on as COVID emerged, where we were trying to decide on hospital policies that started to infringe on people with other abilities and may have been seen as maybe being ageist at times too for folks who are older, to now and the past few months, as we've seen, where the communities hardest hit are communities of color, Latino communities, African American communities within the U.S. And it's just, you know, this crisis just seems to be just highlighting our problems that we've had all these times, but really bringing them to light. I'm really glad to be here and proud to host this panel, because I think this is a really important panel. We have a great group of folks who are doing, you know, the real work. They are their boots on the ground, working closely with communities. And so I think their stories are going to be important for us as we move forward. I love yesterday how I think it was Michael who brought up, you know, Stephen Covey or whoever Stephen stole it from, the fact that, you know, we need to listen to understand before we can be understood. And so today I know, even though I'm moderating, I will be doing a lot of listening to our panel and talking about some of these issues, as well as thinking about some of the voices that aren't here. You know, one of the voices that isn't here are those who are incarcerated, which oftentimes reflects a lot of the other social identities that we'll be discussing today, whether it be about race or ability or things like that. We do have a large amount of folks who are incarcerated who are Black or brown skinned. We also tend to treat folks with mental health issues more with our prison systems than we do with our health systems. And so I think that's something to keep in mind, and also keep in mind the communities and the populations that you all work with as you go through. But I don't want to spend a lot of time talking about the background. I think we all have a pretty good idea of the racial and economic and other issues that have surfaced under the pandemic. So I would like to just turn it over to our first speaker, if you would. Mario, do you have a slide for Anna? And I'm just going to give a brief introduction and let everyone, the panelists, kind of introduce themselves as much as they want, because I'd rather them focus on their stories and the folks that they're working with. So I'm going to turn it over now to Anna Chavez, who is an in-home family support specialist with the Differential Response Program in Orange County Social Services Department. Thank you, Anna.
Good morning, everyone. I am very happy to be here and be part of this conversation, which is very much needed and very significant, especially at a time that we are now. So I have a lot of background in domestic violence programs and domestic violence advocacy, and that is what I will be speaking on today. So Mario, can you move on to the next slide? So I was approached with, the question, if you had to present a story, which one would it be? And I immediately thought about Maria's story. But before we go into Maria's story, I wanted to talk a little bit more about what domestic violence really is, what IPV really consists of. So we're able to understand now the challenges that Maria is facing, not just with domestic violence, but with COVID-19 as well. If we go to the next slide, we have here the basic definition of what IPV is. And it's always used interchangeably between intimate partner violence and domestic violence, but it is defined as violence perpetrated towards another spouse. It could be a current, a former spouse. It could be someone that wishes to be a partner. And there's many different forms of IPV. There's the physical, which we're most aware of, and I think it's the most visible one when we think about domestic violence. But we also have the verbal, the emotional, the economic, sexual, spiritual, psychological abuse. And some of those other forms of abuse is what Maria's story will consist of. It does have physical abuse, but what she found throughout this process was that the psychological abuse was the most detrimental in her situation. If we go to the next slide here, we have the basics of domestic violence, which is the need for power and control. And this is called the power and control wheel, which is very useful to understand what domestic violence really looks like in the home and how different perpetrators are able to use these forms of power and control over their significant other. We have here, using economic abuse in terms of, preventing someone from getting a job, which we'll see in Maria's story is a huge factor in her relationship with this individual, preventing her from having her own money, preventing her from saving. We also have here using the children against the individual and making them feel guilty about the decisions that they're making in terms of wanting to separate the family or wanting to separate the children from the other parent. We also have using isolation. And when we talk about domestic violence, isolation is perhaps the biggest factor in relationships because the person feels completely alone. And over time, no one knows, what's really happening to me at home. No one really understands my problems. And if I were to leave, where will I go? I have no friends. I have no family that supports me, or no one knows what's going on. But we'll see with COVID-19, it's way beyond that form of isolation. It becomes a deeper issue and perhaps the biggest issue with domestic violence and isolation. COVID-19, in a sense, has created this, good environment for this type of violence to grow. There's other ones here, the emotional abuse, using intimidation, which again will contribute to how Maria responds with domestic violence in COVID-19. And it's a huge issue. If we go to the next slide, we have here some just basic statistics. And IPV, domestic violence, is a huge, significant public health issue. It is very common. It does not care who you are or where you come from. It is, we see here that 1 in 5 women will be impacted by physical violence, and 1 in 7 men will be impacted by physical violence in their lifetime. So that is a very significant number that we need to take a look at, and it's there and it's present, as well as other statistics here that we have of sexual violence, right? And in terms of how we're reporting stalking by an intimate partner. So the conversation of how important is this topic, we have the statistics to prove that it is a very important topic that is existing way before COVID-19, and it's very significant now. So now that we have this background of what domestic violence is and what it looks like, and I can talk about domestic violence forever, but if we go to the next slide now, let's start talking about Maria. And now, when I first met Maria, it was late February of this year, early March, and I spoke to her over the phone to schedule our first in-home meeting and visitation, and she sounded very happy. She sounded very, full of spirit and very, very just looking forward to her future. The reason why she came into contact with our agency, there was a Child Protective Services report that was made where the kids had witnessed domestic violence between her and her spouse. Now, when it comes to that kind of situation, we try to go in with preventative work, and that is my role in this situation. So Maria at that point had gone through a domestic violence incident where the perpetrator had actually assaulted her physically, and he was taken out of the situation. But the whole incident resulted because she wanted to find a job, and for the first time in their entire relationship of 14 years, she said, I need a job. And the fight initiated because of that. And she says that the incident happened and the police came. She called the police for the first time, and she went to her first day at her employment. And when she came out of that first day, she felt so validated. She felt so needed. And she told me that I have never felt so good about myself like I did that day, that I called the police and then I went to work. And she says that even though I stand for 8 hours a day washing dishes in the back of a restaurant, those $400 a week that I get is the best feeling that I've ever had. And she was very happy for that progress. Now, when we think about what happened 2 weeks later, that's when the whole shutdown of California happened. And unfortunately, Maria's employment was one of the ones affected, and she was no longer able to work. And as I continued speaking with her over the phone, I noticed that her energy was decreasing significantly, and her hopes was decreasing significantly. And the reason why is she not only was a victim of domestic violence, but also is undocumented. So she does not qualify for any kind of economic benefits, any kind of unemployment. She did not qualify for any kind of stimulus checks, even though she has 5 children who are citizens. And she was forced to remain in the home with this individual and his family. And that is when the hostility, began. She would report to me that he would tell her, if you leave, you're going to get sick and you can't come back. You can't take the kids with you. If you decide to go find another job, you're going to get sick, so you can't live here anymore. You're going to have to leave the kids. She had plans of leaving with family who live up north, and she was told, you would have to leave at least the older kids behind. And for her, living in this environment of no economic stability and nowhere to go, really put a toll into what her self-esteem was looking like, and what her hopes were looking like. Now, when we talk about Maria, it's significant because she was on the path to feel better about herself, and she was on a good path to feel stable and to feel self-sufficient. And that's exactly where we want all survivors to be. And I would always constantly tell her in the beginning, wow, you have the best attitude, you're going to be great. And then as this went on, and as the hostility increased and as the intimidation increased, then we started seeing a different side of Maria, where she was right back to where she started. And she told me, I feel trapped again. There's nowhere I can go. there's nowhere I can take my 5 children. There's nowhere that, you know, they would employ me and I would have enough to support all my children and myself. And we did try connecting her with different housing resources, but unfortunately the main barrier was the lack of income. Now, when we speak about Maria and how impactful that was for COVID-19, it really did, you know, open my eyes into what is happening, you know, what was missing and what is this gap that we need to fill. Maria is one of the many individuals that is going through something like this, that want to be self-sufficient, that want to be stable, but unfortunately the added pressures of COVID-19 is making it impossible for her to find employment, to move out, to be able to be on her own. And she sees herself in this situation right back where she started with this individual, where she does not feel safe and where she doesn't feel like she belongs with her and her children. And we move forward to my last slide here. I know I have like about 10 minutes. What is, you know, domestic violence and COVID-19, and what are the presenting problems here? And one of the main ones is going to be, like I mentioned before, isolation. And it is so huge because now we have limited, you know, resources to a lot of different things. And when we talk about isolation, I mean, one of the biggest contributors is going to be, you know, our inability to go get a checkup. And a lot of information for domestic violence is presented to us when we go to a physical checkup every year you know, at our clinic. That is when the nurse typically asks us, is anybody hurting you at home? We don't have that anymore because of, you know, COVID-19. There is that step that we're missing now in asking people, are you safe at home? And if you're not, here are the resources that you might need. Isolation in terms of some people don't have access to information. So a lot of people, the misconception that domestic violence shelters are not open, that they're not operating anymore because of COVID-19, where that in fact is not real. There's all of them are open, but that's the lack of information that's being presented here. Another form of isolation, like I mentioned, is, you know, the abuser, the individual at home, mentioning that, you know, you can't leave. If you leave, you can't come back. If you're sick, you can't come back. You can't take the kids anywhere. You can't go anywhere. And oftentimes that was a lot of, you know, that creates that isolation and intimidation where the person feels, again, trapped in their own home without all these resources. When we talk about added stress factors at home, we're talking about economic stability as being one of the main ones. If we have, you know, everybody, you know, at home and there's lack of income, that increases the stress factors at home and increases the chances of violence. And it's very interesting because we know that this is happening at homes, but yet calls to domestic violence shelters in the National Domestic Violence Hotline have decreased. And we see that pattern and we think about, well, we know it's rising, but why aren't people calling? And again, we talk about that isolation and we talk about the lack of resources and we talk about how people are not really aware what those resources might be, since one of the main ways that they would receive those resources was when they would go to the doctor. Another form would be that the kids are home now, and the lack of parenting skills. So if you have the children all day at home and this person is already susceptible to violence and lack of frustration tolerance, we're going to see a lot more violence at home with the person's inability to deal with stress. So that's another form of you know, presenting problem with domestic violence in COVID-19. And lastly, we have the limited resources, like I was mentioning earlier, that we're missing that part where we're engaging and where we're doing outreach. Outreach has to look different for us now. It has to be virtual outreach in a sense, but we have to continue doing that because it moves right into what are some possible solutions. And this is where I invite you all to be part of this conversation, to help, you know, bring awareness as to what we can do differently, because we might recognize the problems. That is an easy thing to do, but how do we come up with solutions to, you know, make this problem a little better? And one of the main ones that I've always believed in is prevention. If we can prevent domestic violence, we're going to be ahead of this curve in terms of what domestic violence looks like in our community. Prevention in many ways could be, you know, parenting skills. It could be creating healthy environments for children at home. It could be, you know, engaging in in-home support services where we're teaching healthy family skills to people that are at risk for violence. It's breaking that cycle. And if we can do that, we're able to do that, chances are that we're able to really decrease the numbers of domestic violence. Another thing that we have here is the organizational policy change, and how do we ask organizations to change their policies? And I know that many domestic violence oriented organizations are currently now changing virtual, right? There's virtual personal empowerment classes, which is awesome that we still have that kind of support group going. Even if we can't be there in person, we can still attend these support groups online. There's also now the ability to text in a hotline instead of calling, which is significantly safer for a lot of people that have the person at home and they're not really able to call a hotline. So the texting is awesome. The email is awesome, that we see those. And one thing that I was really thinking about is if people have less access to, let's say, clinics and that kind of environment, but everybody has access maybe to supermarkets, to Target, to Walmart. Why don't we see IPV domestic violence informational posters at those locations? Why do we make it such, you know, a taboo topic that only is available to you in the safety of conversation with you and a nurse? So that could be something that we look out for in terms of outreach, in terms of how do we get those resources to the next person, and how do we advocate virtually, and how do we always, you know, increase the resources for people that are going through situations like these that need that kind of help. So I leave that to you, and I hope this was informational and helpful. Again, I only had 10 minutes, so I could talk forever, but if you want to be part of the conversation and help think of solutions that we can, you know, use to advance and to close this gap, that I invite you to do so. So thank you for listening to me. Thank you for being here with me. Stan?
Thank you, Anna. And we do have a couple minutes, and there were some questions that were posted, so I thought maybe we'd answer a few of them real quick. One of the first ones is, what strategies can public health professionals do to protect clients who are victims?
Yes, and again, I don't know how it works with everybody, but I know that there's usually a questionnaire, and we've talked about how the questionnaire feels to, let's say, patients that, you know, you're giving a sheet and, you know, read these and tell me if any of these are yes. Sometimes that becomes very impersonal, given a questionnaire and just, you know, minding your own business and letting the person answer. And I've actually asked a nurse, you know, what would happen if I said yes to any of these? And I remember she just looked at me in shock, like, what? I don't know. And I told her, not that it's happening to me, but I just want to be more informed for when I let people know that this is a safe space. What happens after? What happens after, you know, someone says yes? And for healthcare professionals, I encourage you to have the conversation instead of just the sheet. I encourage you to really ask if anyone's hurting you and what could happen, or what are your resources, more so than just the poster posted or the questionnaire that's handed out to patients.
Another question is, are you seeing an increase in violence due to the increased alcohol and other substance abuse as more people are relying on substances to self-medicate to manage stress?
It always goes hand in hand. And again, we talked about the frustration tolerance, that, you know, it's significantly decreased. And yes, a lot of people are using those methods in terms of how to relieve stress. But we were just talking about this in our own agency, we're seeing less and less reports of domestic violence. And we asked the question, why is that happening? And again, it's because of the lack of resources, and it's because, you know, people are not really aware that, you know, we're still open, or domestic violence centers are still open. But there's going to be a lot more significant numbers afterwards. And if there's a lack of frustration tolerance, and this is a way and an avenue to deal with that frustration, of course, we're going to see an increase of violence there.
We'll do one more question. Someone asked, what if they don't have access to a computer or internet for virtual visits? What do you do in those cases?
That is the tricky question. And that's when we talk about organizational policy change. And we're not able to have contact with the person both via phone or via computer. And that's one of the main resources that we're, contributing to this virtual advocacy. It is very important if you're, here listening and you're going through something similar, if you know someone that's going through something similar, reaching out to them and connecting with them, and letting them know that there's still resources out there. And that's the trickiest part of this all, that we can't reach everyone how we are right now. We can't reach everyone affected. And it's in a matter of really, pinpointing and knowing in our community who might be at danger and who we know is not well, or who we haven't heard of from a while. And maybe connecting with them and letting them know, is everything okay? And in turn, really referring them to different resources then. So that's one of the main things that we should be doing right now during COVID-19, really taking care of each other and knowing that if someone is going through something difficult, really, advocating for them. Anyone could be a domestic violence advocate. It's just a matter of really recognizing when something is going on and really offering that assistance.
All right. Well, thank you, Anna. Thank you and I'm sure you're going to stick around, so we may have time for some other questions at the end. And there were several other questions, so we'll see maybe if we can get answers and post those later. One that I loved is at what point do we hold men accountable? Which I think, we've talked a lot recently about the institutionalized racism and how that plays out in policing in our criminal justice system. We haven't talked so much about the institutionalized sexism and how that plays out in our correctional systems and justice. And so that could be a whole nother, hour and a half.
Oh yeah. Oh yeah. That's a whole other presentation. And in terms of this presentation, we're not just focusing on women. Men are also victims, like you said. Like you saw in the statistic beforehand, 1 in 7 men are affected by domestic violence, and 1 in 5 women. Of course, women are more present and it's more invisible in women, but for men, it's just as much. So when we talk about IPV and domestic violence today, we're talking about both groups.
Excellent. Well, thank you. Well, thank you, Anna.
Thank you.
So we'll move on now to Susie Newberry. Susie currently works at Genesis Rehab Services as a clinical director, also university relations director, and a speech language pathologist, and is based in San Diego, California. Oops, wait, were we supposed to go to Ernesto? I might got the wrong. There we go. Sorry about that, Diana, if I messed that up. But this is Susie, you ready to go?
Yep, I am. Hello. Hi, everybody. Good morning. If you're on the West Coast, it may be afternoon if you are elsewhere. My name is Susie, and I am a speech language pathologist by trade. I got my master's at the University of Boulder, Colorado, and I currently work as a clinical director and university relations director at Genesis Rehab Services. So Genesis Rehab Services is a large rehab company nationwide that provides physical therapy, occupational therapy, and speech therapy and respiratory therapy services to our geriatric community, our older adults. And this has been one of the most vulnerable populations with many medical complexities that has been affected by COVID-19. There have been many challenges, and you guys have probably seen in the news, as we all have been glued to the news cycles, about different populations that have been affected by COVID-19, and our elderly population with those medically complex needs has been one of those. So today I am going to discuss some of those challenges that we experienced in the skilled nursing and long-term care facilities, as well as some of the assisted living and independent living facilities that we service. Next slide. So when we think about our older population, those that are living, they reside in these long-term care facilities due to either having really complex needs that their families cannot accommodate in the home environment, or for many other reasons, some of these adults are living in our long-term care facilities. So during COVID-19, due to extreme infection control that we have to do to try to keep our staff and our residents safe, our residents have unfortunately had to isolate to their rooms for infection control. So usually in our facilities, if you haven't been to a skilled nursing or long-term care facility recently, there's usually communal dining. They can go down to a dining room and eat with their friends and their peers. There's robust activities. We do bingo. We have a walk to dine program. We have lots of different programs that are specific to each building and each of our building's population's needs, like specialized to that that building. But with having to be isolated to their rooms, none of this is happening. There is no community activities, no activities in the building. So instead, during COVID-19, as we all heard about the PPE shortages and everything like that happening, infection control became the primary focus for patient and employee safety. So we are being very vigilant about our hand washing, which we have to take a whole different approach to sometimes, which is what my case study is going to be about today. One of the main challenges with some of our older adults with those medically complex needs, and also some cognitive impairment. Many of our residents have some form of cognitive impairment, be from mild cognitive impairment through the different stages of dementia and the different types of dementia, which I'll talk about in the next couple slides. But we are going to focus on really hand washing for just general preventative infection control. And for our residents, some residents actually are wearing a surgical mask as well. So the proper donning, putting it on, and doffing, taking the mask off without contaminating the outside germs getting on the inside of the mask. So that can be a procedure too for people that have not done that before, that people may have a cognitive impairment or maybe fine motor or gross motor issues as well. And with our staff, we had to make sure that the infection control with necessary PPE for patient care was taken care of, be it in the COVID unit. I do help to act as a clinical director for multiple California designated COVID units, or COVID buildings that have a specific COVID unit or hallway in each building. So the infection control for those with the coronavirus is very different from our regular residents that just live in this facility. So I just wanted to kind of go over where that focus had kind of shifted from being more this really engaging communal activities to now with COVID, everything switched to infection control was first and foremost the most important aspect that we were addressing. So today's case study is going to talk about California designated COVID facility in Los Angeles County, north of Los Angeles in the Valley, San Fernando Valley, if you're familiar. And the challenge was with this particular long-term care resident reinforcing infection control of hand washing, with this long-term care resident who had advancing dementia. So when we looked at her medical record, dementia definitely stood out as, okay, this is going to be a specific medical comorbidity that we definitely have to take into account in trying to figure out how we can assist this resident in really adhering to the hand washing protocol. So before I get into the specific case study and what our creative solution ended up being, I want to talk about what dementia is. I am a certified dementia practitioner. It is one of my passion areas. I love putting on my detective hat and trying to figure out how we can help our residents with dementia. And one of my favorite phrases to think about, which I think can be applied to all different walks of life, but especially for those with dementia, is all behavior is communication. So we have to think about if there's a behavior that's happening, if people are yelling out, if they're trying to slide out of their wheelchair, if there's some sort of behavior that's happening, if they've stopped eating, what is that trying to communicate? There's something that that resident is trying to communicate. So when we're thinking about dementia, I want you to think of it as not a specific disease, but it's actually an overall term that describes a wide range of medical conditions caused by abnormal brain changes, these plaques and tangles in our brain that interfere with our daily life. So there's many different types of dementias, and those are defined by the different areas of the brain that they affect. Dementia is a progressive disease that starts out slowly and gets worse. Someone does not wake up one morning and have dementia. That is not the way the disease process works. If you notice a huge cognitive change, a change in someone's thinking ability overnight, that may be more likely due to a delirium, due to an acute infection, UTI that can in our older adults can drastically affect their cognition. So there are all different types of dementias. One of the ones that we hear about the most is Alzheimer's disease, which primarily affects the memory, but there's different dementias like Lewy body's dementia that also has hallucinations, auditory and visual hallucinations. There's all different types of dementia. So I just wanted to kind of lay that framework down for those that might not be familiar with that disease process. Next slide. So we did go over some of those changes that can happen in the brain with dementia, memory loss being the primary marker of Alzheimer's disease, but also language loss. So that's why I started out talking about that all behavior is communication, because in the later stages of dementia, some of our residents are going to lose their expressive language, their ability to talk and express themselves verbally. So that's why we really have to think about what are they trying to express with their actions. And a little tidbit, since I am a speech therapist, I am totally intrigued by the fact that language and music are in different centers of our brain. So if somebody cannot verbally express themselves, they may be able to hum a tune or sing with you an old hymnal that they remembered from when they were growing up. So I think that's really interesting for those that may be caregivers out there and wondering, how can I better communicate with my relative that has dementia? How can I better interact with them? Music is always a great tool for that, especially if you're bringing up old songs from their long-term memory. So I've listed here some other different changes that can occur with dementia: decreased cognitive thinking abilities, and also changes in behavior. If, say, our person has a frontal temporal dementia, in this part of the brain, it's going to change their inhibition, their personality, their feelings. So people have reported, and I have seen, that personalities can drastically shift too, and that is because of those tangles and plaques in the brain. Next slide, let's get to our case study. So our case study is a long-term care resident in our facility, this COVID designated facility, with advanced dementia. And she was refusing to wash her hands. She was actually refusing to go in the bathroom in general, to either use the toilet or to wash her hands. And she had a history of falls in the bathroom. So we're trying to put our detective hats on and put all these pieces together. And we're thinking, okay, so she might be scared of going, or apprehensive to go in the restroom because she's had falls. She has a negative history in the restroom. Also, we have to think about with our residents with dementia that it's a very loud environment in there, a lot of hard surfaces in the bathroom. You flush the toilet, it's very loud. And then water. Water is clear. We can't see it. So if you have older adults in your family that might have dementia, they might be refusing to shower. And that may be because they're scared of the water. They can't see it. And then all of a sudden, little pinpricks are hitting them, or they can't see the water coming out of the faucet, and all of a sudden they're feeling this sensation. So that can also be a little bit scary to them. So next slide. Our speech therapist and occupational therapist were going through their checklist with their detective hats on, trying to figure out how can we help this resident adhere to this hand hygiene precaution. So they tried hand sanitizer. Didn't work. She refused it. She didn't want it. They tried different soaps. She actually was taking showers, but just didn't want to wash her hands. So they tried the soap from the shower. That didn't work. They tried a hard soap, like a bar of soap. They tried liquid soap, everything possible. And then they assessed her fine motor. Was it possible that she wasn't able to do the actual movement of washing her hands? But her fine motor was intact. So they were trying to really drill down and figure out what was this root cause that was causing her to refuse the hand washing. Our speech therapist, which is again my discipline, thought about those different cognitive abilities. So remember, cognition is something that's affected by dementia. So was she not able to sequence the hand washing? Did she not remember that the coronavirus was happening in our society and that hand washing was so important? That's another huge issue that has been so challenging with this population, is memory is affected. So we're having to put up a lot of visual signs, reminders about what's happening. We have COVID-19 right now. These are the precautions you have to take because the memory is not intact. So that's extra confusing, right? Because our residents get their cues from the environment, from their caregivers. And now the caregivers have all these layers of PPE on. They can't even see this nurse that they've known for 5 years. All they can see is her eyes underneath a face shield and a N95 mask and a surgical mask and a gown and a hair bonnet. I mean, it's very disorienting to our clients right now, which has been a huge challenge, in addition to the social isolation of having to stay in their room all day. So speech therapy, our speech therapist is going through all of these cognitive skills. Is it the sequencing? Is it the memory? She created a visual aid for the sequencing of the hand washing to help with that memory deficit. And then she trained the caregivers to help with that initiation, trained the CNAs, because sometimes initiation can be affected by dementia. Maybe she just couldn't start the process of hand washing, but once started, she might be able to complete it. Alas, none of those worked. So we were getting to our wits' end thinking, what is the root cause of why she won't wash her hands? And this was our solution. Next slide. What was the missing piece of the puzzle? What had we not thought about? We looked at her medical diagnosis. We had thoroughly gone into that. But what hadn't we gone into? Her background, her history, where she was from, that person-centered, person-first care. So we forgot about cultural competency. We had to go back, take a few steps back, and just go back to the basics. Call her son and say, hey, tell me about your mom. Tell me about where she grew up. Let's just get an occupational profile about where she grew up and what she did. So she was born in the Philippines and raised in China. So she had a whole different set of cultural hand hygiene procedures that she had grown up with. And remember, she has advanced dementia. So she is not in the current day and time. She's more residing in her long-term memory of when she was a child. So we had to go back to that patient's story and really go to that root cause of why she wasn't doing her hand washing and how we could possibly mimic what she had done previously in her life to help with this infection control. And this was our solution. Next slide. The solution, after an interview with her adult son, was to use a culturally appropriate adaptation made to facilitate hand washing. So this is a picture of a taboo, which is a bucket that sometimes has a ladle that is used often in the Philippines to help conserve water, because running water might not have been readily accessible when she was growing up, and it can be used for hand hygiene as well as like a bidet in the restroom. So we adapted this. We didn't have one exactly like this, but we took an emesis basin, we put water and soap in it, mixed it up, and this triggered her long-term memory to think about hand washing like she did earlier in her life, made it a more culturally appropriate, person-centered way for her to do hand hygiene. And before, she was totally refusing, and as soon as we introduced this, she was doing it totally independently. All we had to do was do the setup for her, leave it at her bedside table, and she would do her own hand washing, because it was that culturally appropriate, culturally competent, person-centered first care. So we unfortunately were focused on that medical model at first, really looking at her medical comorbidities, and we missed that piece of the puzzle. So my kind of lesson for today is that we always need to be looking at the person first, talking to them about their experience, where they came from, in order to give the best care, the most relevant care possible, and to really improve their quality of life the best we can. So that was just one challenge and a creative solution I wanted to share with you guys. Before I sign off for the day, I want to give a shout out to all those essential workers out there, the therapists, the CNAs, the nurses, the maintenance workers, the housekeeping, dietary, all these people that are working day in and day out and are literally the only people that these residents can see right now. They have become their second family since this has been happening since late February, March, where visitors have not been allowed in our facilities. So our employees are working 12-hour shifts, are doing whatever they can, because they are now these residents, these patients' new family for the time being during COVID-19. So just want to give a shout out to those wonderful hard workers out there with hours and hours of PPE on and are showing up every day. So just wanted to share that story with you about another population, our older adult medically complex population that has been really affected by COVID-19 this year. Thank you so much. Passing it back to Stan.
Well, thank you, Susie. I think we have time for one quick question if you'd like. We do have one. They say, how do residents track that they have washed their hands? Do they have a chart or some sort of visual or oral tracking? Like Alexa, the hand washing song, something like that.
That is a great question. And we have lots of different tools for that. Some residents, depending on their ability, their cognitive ability, we can put a tracking form in their room and have them track it to really take control in that health literacy sense of their own health and their own hygiene and infection control. For those that, like the resident I was talking about, that has more advanced cognitive impairment, that would be tracked by the nursing and CNAs, the staff, who would be tracking it before any interaction with other residents or before meal times. Then that would be tracked and logged as well. That's a great question. Yeah, infection control is so important right now, and it is something that has to be tracked and be very vigilant. Thank you for the question.
And then one other quick one. Are you seeing an increase in dementia-like behavior among people due to the disorientation caused by the pandemic, not being able to see family, those sorts of things?
Absolutely. Absolutely. It's really devastating. It is so devastating because, like I was saying before, our residents get a lot of their cues from their caregivers and their environment. And they aren't going down to the dining room and seeing Joe and Sally like they used to at lunch every day. So we are seeing some more behaviors. We're seeing, due to social isolation and loneliness, that can contribute to depression, which depression is linked to decreased cognition. So we're seeing decreased cognitive function, decreased physical function because people are in their rooms. They aren't getting out of their beds. Their ADLs, activities of daily living, getting dressed. They aren't getting dressed. They aren't, like we've been doing for the past few months. Maybe we're staying in our pajamas all day, because we can. But we also have the option to get up and walk around our house or things like that. But some of these residents that may have more complex needs, they don't have the option to get up and like walk around the facility. So we are seeing different cognitive and physical challenges, as well as behaviors like the question had mentioned, because there's only so many ways to get that stimuli if people need to get that internal stimuli because they aren't getting the external stimuli. So maybe extra vocalization, some yelling out because they aren't getting that external stimuli. We have seen increased behaviors like that. Or that they're just so unhappy that they're in their rooms all the time. And we get it, and we are trying to do everything we can. We're being really creative with our in-room treatments that we're doing. We're doing activities the best that we can. We've even done karaoke room to room with like a wireless microphone, and then infection control, trying to engage any way we can, because loneliness and social isolation has been an epidemic in our older population for decades. And then you add a pandemic on the top of it, which forces physical separation. And it's really become an issue that is at the forefront of our industry's point of view right now. And we're really trying to get it in the forefront before it escalates even more.
Right. Well, thank you, Susie. Stick around. Maybe we'll have some time for some more questions. I think there are also a few more questions on if you want to type in answers, so that we're trying to answer everybody's questions if we can.
Perfect.
But we need to move on to our next panelist, to Miss Ernesta Wright. She served as Executive Director of the Green Foundation for I'm not sure how long, but has over 30 years experience in community health education and more than 32 years experience in entrepreneurial experience. And so we welcome Miss Ernesta and look forward to hearing your stories.
Great. Thank you very much, Stan. I really appreciate it. And thank you, IHA, for giving me this opportunity to be able to be a voice for this industry that I'm going to share with you about 3 stories of how the healthcare industry is being impacted. And it's very important that the bio that you saw, you'll see that, yes, the 30 plus years of entrepreneurial and the 20 plus years of the Green Foundation providing health education, particularly in the African American community, to provide comprehensive healthcare services, and we offer navigation services. And so this industry is very kindred spirit to what we do as in the community, because some of you may know that oftentimes in some of our evidence-based practices, how important the salons are able to help get messaging out in certain communities, and particularly the African American and Black community. So our heart goes out to them when I'm hearing their stories. And I did have a community health intern to assist me in reaching out to some of our stylists and hair salon owners who have been supporting our efforts for many years. We wanted to hear from them. We often hear of the mainstream, the restaurants or the deliveries or the larger industries, but I wanted to look deeper to find out, what about this industry? How do we amplify their voice? And so this opportunity gave me a little bit more insight to actually talk one-on-one with them, that I wanted to represent their voice, and they all gave me permission to be candid in their responses. And I want to share with you, the bio looks good, but I am passionate about making life more equitable for all. It doesn't matter of what you look like, because I do believe in humans has just rights of just living a life of whatever they choose. And so how do we have that conversation and having sometimes those difficult situations or conversations to be able to tell people stories, to be able to help assist others in their journey. And I appreciate all the colleagues who had shared before me of some of the sadness of what is happening and occurring because of COVID-19. The healthcare is no different. And so the 3 people who I've shared with, that they're all are owners. They're literally owners for many years of hair salons. And they're having some of the impact. And I'm going to share the next slide. What is the impact of the service? It's interruption, which created financial hardships. They have children, they have loved ones that they're taking care of. Safety for themselves, for their staff and their patrons. And the stay-at-home order, yes, it is to keep us safe, but what it has done for their industry is definitely create a financial hardship. And some of the unfortunately stories is by them being independent or being a small business owner that they did not have a lot of money tucked aside for a rainy day. And those who had set aside money for a rainy day, they didn't have money set aside for a pandemic like most of us haven't had, wasn't looking forward to a pandemic or prepared for a pandemic. And we're still struggling as a nation to wrap our arms around of what is really happening. And as some had shared before me about the impact in African American communities of how this is highlighted, that existing evidence-based practices has been around for a number of years of how health has been, it has many disparities and inequalities from actual getting service to surgeries to diagnoses or just quality health care. And so when we're talking about this industry has supported all of our efforts in the community-based space. So when they're impacted, we are impacted as well. So the next slide. So the trend is unknown because one, we know that systemic racism impacts sometimes the financial industry where they're not able to get the loans that's necessary to be able to keep their business afloat. They're not as informed or being informed because the information may not be shared as far as where the loan, where the assistance or the support. And so we as an organization have continually have connected with our partners of being able to share some of the resources. We consider ourselves a command center now that we've been contacting one by one. Did you know about this loan? Did you know about where you can get support? Did you know about support services in your community? So we use the navigation arm of the Green Foundation to help support these individuals who are not necessarily very informed. They have a business and it's about clients and maintaining their clients. And so this is an untreated for them. They are uncomfortable, they are scared, concerned, not only just for their business, which they still need to make rent, even though they're not having clients. So that continues to give them concern. And of course, the concern for their clients and family, they all want to make sure that their clients are well and as well as staying safe. And at the same time, they were in the same hat that their family is going to be very much impacted because they're not having clients. So of course, on the books, as they called it, a lot of appointments were canceled, and some of the frank conversations with their clients and these are clients that they might have had for many years, are apologizing and saying that I just can't take the risk of coming in and getting a service done and impacting my life. And not only that, the lives that people that they live with, those who are surrounded, as well as their working at home, of how that was going to impact them overall. And I want to give you some insight of what this industry really does for the community engagement. For the 20 plus years that we've been able to do some work in Orange County, that the salons and the salon owners are very much our resource because their clients come to them every week or once a month. So the information that we may have to share, whether it's for COVID-19, the US Census, or prevention and wellness, that we have established long-term relationships to be able to drop off materials, drop off incentives, or able to come to their salons to do in-service education, or to be able to invite clients to some of our conferences that we've had over the years. So they're very much an integral part of reaching the African American community here in Orange County, but it's also known nationally as well as internationally, because the industry itself is not just getting your hair done in the African American community, and it also relates to the barbershop as well. That is a place of community. It's a place of kindred spirit. It's a place of safe space, of being able to share, express. It's a place to talk about your family. It's to talk about politics. It's about your entertainment or what's in the know. These are people are part of your family now, so it's not just getting a service. It is more of part of your family and part of your relationship. And it's for us as an organization, it's but part of our relationship building. So am I concerned when their clients are concerned? Absolutely. When they're concerned and their families are concerned, absolutely, I am concerned. So the next slide is, we're talking about the social injustices, the brutality, the health and well-being. How can we act the action reduce systemic inequities among African American Black communities? We hear that often, but it's just very simple. It's a matter of sympathy as well as I add empathy. Ask yourself your question that if your son or your daughter was walking down the street and that they were stopped for no reason of just being who they are, that creates over time stressors, unnecessary stressors. Or if you're going into a grocery store and that you're being targeted just because of just who you look like, those are stressors, and those really do exist. So I would ask, when you're asking yourself, what can I do? Ask yourself, how can I make the change of making sure that all individuals have the common right, the simple basic right to live a healthy life, whatever they decide a healthy life is for them, as long as it's within their families and as long as it's obviously legal. But everybody really wants that same right, their families to come back home safe. They all want to go to work and come back safe. So ask the question, what am I able to do to help shorten or reduce the injustices? And that is, like I'm teaching right now, the advocacy and training and leadership. Contact your city council members saying, I am concerned for this community. That's an email, telephone call, or when you're in part of a meeting and someone is saying something derogatory and it's not factual, then you have an opportunity to step up and ask for clarity and maybe having a little bit more engagement of making sure that the facts are shared, as well as, is it true? The other wonderful thing about being able to do this is contacting police department, contacting them to find out what kind of training, what is the training in other international organizations that have no deaths by the hands of police versus what we're having in America. And it's training. Ask about what is the training, what's being done, because that impacts all of our health and well-being. And from a community based in African American Black, that when someone dies, even if it's in New York and you live in Orange County, you feel that from a human being. So feel the death. Feel it, because human nature, no one wants to feel death. No one wants to see it. So it's no different. So it is literally, you're taking off your hat and feeling that empathy of another life, especially when it's senseless. Not talking about the other areas. We're talking about the senseless areas of the inequalities of how it treats and how it's impacts individuals. So how this is impacting the industry, the three people that I contacted are salon owners who've been a part of this industry for over 15 to 20 years. They are very scared of the industry that they used to love and been a part of. And now that their skill sets have all been in this industry, so they're concerned about now what? What is this new normal that's going to take place? And for us as an organization, and helping them, and they've been a part of our community engagement, that is still a big chunk of us being able to get that messaging out to those places, to get them keep pushing out the great information that we always hand off to them. So they're saying, what is it going to do for me after the pandemic? What does COVID-19 look like? And so what I'm saying and sharing with them is that they become advocates for themselves to find out how are they going to be able to reinvent themselves through this pandemic during this time, as well as what's the after fact. What does that look like? Why is it what is going to happen to this industry, because it's up and personal when you're getting your hair done. It has impacted me quite a bit. I've learned to do my own. I usually wear my hair very short, but that's not the case, and I really want to make sure that I stay healthy as well. So it has impacted a lot of us. I hear a lot of news anchor individuals talking about can't wait to get a haircut. I'm hearing celebrities, men talking about can't wait to get to the barbershop. So it has impacted, and so we take some of these things for granted, you know, when they were all available, but in how they've been impacted on a personal. One of the stylists and salon owners have shared with me that her clients of many years had collected funds for her to be able to pay for her rent for the next 3 months, because again, even though she's not receiving clients, but to hold her salon space, she has to still pay rent. And so they got together and collected money. They also did a GoFund account for her daily living. And one of the ones that I'm talking about, that she's also taking care of her elderly mother who is on Social Security, and it's limited. And she also has 2 young adults living in her home who are off from college break. And so now she has 2 young adults, individuals that she's concerned about, and an elderly mother, and that her income has decreased to literally 0. And so now she's going to be reinventing herself as having, asking her very clients to support her new business, which is creating baskets. So now she's looking at a way of reinventing herself. That's one story. The second story is a salon owner who had applied for, the loan, and she was able to receive the loan. Unfortunately, she's not able to bring her employees back because the employees are concerned of having that socially distance. How are you able to have that social distance, even though wearing protection mask, when someone is getting their hair shampooed, someone is getting a color treatment? Those are close contacts with that must take place to be able to get that service. So her concern is, how do I find experienced employees? And she has the money to pay, but the other flip side of being concerned and very scared to come into the salon to work. And then third and the final one is the male salon owner who has concern about, didn't have no support, didn't know where to go, and not sure if he's going to be able to keep his doors open, and that he's been in the business for over 35, 40 years, and a lot of salons in Orange County and stylists that he mentored them. And so now he's facing being sole provider for his family with 2 young girls and a wife. Now he's in a place that he does not have another skill set to be able to help him offset his income because of the stay-at-home order. So he's in a dilemma. So we're having some really candid conversations of getting our heads together to find out what would be areas that will be able to support this industry, because I am very concerned myself, because as I shared with you, that they really are a part of our outreach efforts and getting messaging out here locally as well as in other cities as well. We also have a program in Los Angeles, and I have found connecting and getting to know and build relationships with this industry has helped support it overall health. And so I'm concerned because they're concerned, and I'm not only just concerned of the industry, because I'm concerned because I know from a human perspective how that has to impact them and their livelihood. And so I like to keep it always from a community-based perspective, always conducting ourselves from a human basic need. How can we support individuals from their basic human needs? And so when we do the health education, how do we support you? Where do we help you? And I'm also an advocate of making sure that I have them to own their own least in life, of taking action to make sure that their lives are much better based upon what they learn and based upon the knowledge that they gain through training and workshops and our engagement of how to take those necessary steps to have a better life for themselves by taking action in making a life for themselves. And so last slide, take action and share in hope, humanity, and help. Find ways of being able to help someone. And I here personally live in a complex of condo homeowners, and I create neighborhood days. And someone would say, well, I didn't know this is a national day. I said, I created it myself. I wanted to give you as a neighbor a gift to let you know I'm thinking about you. So let's talk about just neighborly. So just hope, humanity, and help is all that's necessary to help others who are struggling during this time. That's when it really shows up of who you are as a person, what your integrity is, as well as your character. What do you look like when your coworkers, your colleagues are not looking? How are you impacting at the local level? Are you sharing hope? Are you coming from a humanity perspective? Are you sharing the help that you know that you're able to give? And I'm sharing with you. And the next slide. I wish you all well. And thank you for this opportunity, IHA. And thank you for all those who are listening, all 752 of you. Thank you for allowing me to give a voice to this area of voiceless individuals at this time.
Well, thank you, Ms. Ernesta. I really appreciate your experience and what you were able to share with us. And I think we've got time for one question. There are quite a few questions, so you may want to look and see what you can answer. But I think one that resonates with several of us are, for those of us who want to learn more from and engage with that community, what are strategies you recommend?
Oh, very good. It's a strategy that I had to do as a young professional of attending workshops, attending church services, attending community-based organizations, meetings. You have to go and show up. There's no difference, no different than what I had to do of going into a room with an audience that doesn't look like me. But that's the way you learn, firsthand experience, and you'll find some really depth and enriched experiences. The uncomfortability is a human nature, but to really get to know any community, you have to go. So go to church, just go. You don't have to acknowledge it. Acknowledge who you are. People are going to see you and watch the experience of others, how they respond to you. So when you go to a meeting, just invite yourself, buy a ticket or go for free and just sit. And if someone asks you, well, how can I help you? Why are you here? I just want to participate. I really want to learn. People appreciate being authentic. So those are just very simple 1, 2, 3 steps. All you have to do is look in your own local community, find out who is having an event, who is what church service. And now that a lot of services are online, that you could just dial in. A lot of meetings are virtual, so you could just attend virtual meetings to get an idea. And even this training that I was talking about, Stan, and leadership, we have all in ethnicities online. And what I love to do is that I want to include others that don't look like me. What a best way of knowing who I am? By participating. I want you to know firsthand. I want your bird's eye view. So when you're in a room, you can say, no, that's not what I've learned, because now you have the firsthand experience of what you experienced by attending an all Black or African American or being a member of that experience goes a long way, because now it's not what you heard on news or read in papers. It's what you experience is the most rewarding thing that you can achieve by knowing the knowledge yourself, that this is what I've learned. This is my experience. And that gives much more strength to when you have a conversation, a discussion, that you're coming from your own perspective, because this is what you learned and this is what you know.
Well, thank you for that. I love that. I know myself that I learn more when I'm in that kind of discomfort level, when I'm on the edge of what we call our learning edges and things like that. So I'd like to challenge myself whenever I can. So thank you, Ms. Ernesta, and stick around. I'm sure we'll have time for a few more questions at the end, but before we do, I wanted to get to our last but definitely not least panelist, Chris Stigas. Chris is a patient partner on the AODA Council at the University of Health Network in Toronto. He also sits on the Advisory Council on Accessible Transit to the Toronto Transit Commission and holds a position on the Young Professional Board at the Spinal Cord Injury in Ontario. And this year, he was the recipient of the Patty Dawson 2020 Activist of the Year Award from the Spinal Cord Injury of Ontario. So thank you, Chris, and we look forward to hearing from you.
Hello, everybody, and thank you for having me. As you may have heard, I'm a resident of Toronto. I live in Toronto, Canada. And 5 years ago, I sustained a spinal cord injury. And prior to that, I was an electrician. And now I live life using a wheelchair. I live in an assisted living building, which means that it's a mixed use building. There's other people that live in this building that require PSW and attendant services. So we have a shared system. I have staff that comes in multiple times a day. They help me with my morning routine. When I wake up, they help me get dressed. Then they would go to somebody else's booking. Then they come back for my lunch. They'd come back in the afternoon, help me with dinner, and then finally they'd help me with getting back into bed at night. As this pandemic started to unfold and the tragic loss of life became front and center with what was going on in long-term care homes in Ontario and in retirement homes, I quickly started to have anxiety around the people that were coming into my home and how safe they were being. When the quarantine measures came for everybody to go into lockdown and stay safe at home, you know, that sort of had a different meaning for me, and not necessarily feeling safe by having these multiple people coming into my residence in my home multiple different times of the day. And even though eventually they were wearing gloves and they were wearing masks, I started asking questions about how these people were getting to work. And a lot of them were getting to work using public transportation. And at the time, it wasn't mandatory to be wearing masks while on public transportation. And at the same time, they were getting rides from other people in automobiles that the people who were driving didn't necessarily live with them. And I quickly began to realize that a lot of these people didn't necessarily have the training and the understanding about their role in the bigger picture in providing a safe home environment for myself and in providing infection prevention in my home. It didn't just start when they walked through my door. It really started in the community with them. And they were really the only variable that was coming into my home. And as the tragedies were being realized in long-term care homes and retirement home settings, what I was trying to bring attention to is that people living in assisted living or supportive housing that also use this same stream of PSWs were also considered high risk, because the practices and the culture that was going on in these homes and in these settings was the exact same culture and approaches that were happening to me. I was experiencing these things daily myself. And what I mean by that is I started to try, and as much as I wanted to be, oh, this PSW is not good, or this PSW, I began to sort of look deeper into the matter, and I realized that it's more of a systemic problem. And what I mean by that is that these PSWs, they originally started off, from my understanding, as RNs, registered nurses, and then those were too expensive to provide care, so the care was from nurses, and from nurses it got watered down to PSWs, and from PSWs it was watered down to attendants, and then support workers, and then service providers. And we finally get to a point where the people that are providing care for our most vulnerable populations, our most at risk, the people that we have deemed to be essential workers, are the ones getting paid minimum wage. And the lack of training and the lack of certification, the lack of sensitivity training, the understanding of infection spread, and clean procedures. So, and the problem is really from the government recognizing, if they're recognizing these people as essential workers, they need to be paid as essential workers, and they need to be valued as essential workers, because what ends up happening is that they cannot find full-time employment. They can't find employment that has good pay, and they end up working in multiple settings, in multiple part-time jobs, jumping around from one home to another home to another home. And eventually they burn out, they get tired. And once that happens, I'm sure everybody can imagine, you just sort of tune out and you disconnect, and you're at your wit's end, especially when these challenges are magnified with something as a world pandemic. And so I feel that all that being unknown and people coming into my place, the ramifications of that are also see themselves in raised anxiety for me. So I no longer feel safe at home because there's a continuous unknown coming into my home. And when you have the raised anxiety, I started to notice early on in the pandemic that I started drinking more, and their substance abuse and then addiction problems for other people are also start to go on the rise with that type of anxiety. So one of the things that can help with bringing that anxiety down is testing. And I was told, oh, you can go get tested at this center and go to this center. But with public transportation and COVID-19 and quarantine, it's not easy with people with disabilities to get onto public transportation, and they don't necessarily have access into these testing centers. So when you're creating these protocols to keep everybody safe, these protocols can also sometimes create barriers for people with disabilities. And how do you get them tested? How do you get the people that are coming into their homes equally tested? So the protocols and the inquiries and all these investigations that are currently happening into long-term care and retirement homes, they also need to look into assisted living and supportive housing for people living with disabilities, especially since we share the same stream of support workers. And hopefully some of the protocols and measures that comes out of these will be pay hikes and better training for our PSWs that are taking care of our most at-risk population And part of that training and what I meant about realizing their role in infection, as soon as somebody comes into my unit, the first thing they do is wash their hands. They walk in with a mask, then they would glove up. And if they're helping me with dinner, they would set up my dinner. And once I'm set up, I can feed myself. And they're sort of waiting until I need assistance again. And something that I noticed happens commonly is that they would get a text message or a phone call or something would start dinging on their phone. And even though they might not necessarily answer it, they pull it out, look at it, silence the alert and put it back in their pocket and continue to stand there. Well, now you have been speaking on your phone without a mask, and I'm sure there's trace saliva or particles on your phone that you just touched with your glove. And if I don't happen to catch it, and if I don't happen to ask them to re-sanitize, as soon as they help me with my food or readjust something on my plate, now this quote unquote contaminated glove has a direct route to my mouth. Someone's at front door. Excuse me. And these are the sort of training things that are missed, especially when people are taking entry-level jobs and they're sort of just calling us client services. Oh, you're just providing a service. Don't worry about it. Everything should be straightforward. The client will direct you. But there's really so much more on the back end that needs to be considered in order for it to be a team situation and me to keep them safe and them to keep myself safe. Another example of this sort of, for lack of a better word, again, is a systemic barrier to healthcare. When I went to my local disability office to make some changes to some of the service that I was receiving, I put my form in a plastic shopping bag on the back of my wheelchair, and I wheeled to their office. And the lady came to the door, and I asked her to remove the plastic bag off the back of my chair. And she said to me, "I'm sorry, sir, we're not allowed to touch you or take anything off your person because of COVID-19. And I said to her, "Okay, that's fine, I understand, but surely you must have an accessibility accommodation for people that don't have full use of their hands in order to get this piece of paper to you." And she said, "Our accommodation is coming to the door." And I said, "No, that's your COVID-19 protocol. That's not an accessibility. An accessibility accommodation would be to put on a mask, put on a new set of gloves, sanitize, grab the form that I need from the back of the shopping bag and take it to your office and then either clean it, scan it, take off the gloves, dispose of them." So there's also that point where I feel that sometimes the accessibility aspect has been glazed over and missed when we're talking about COVID-19 protocols. And we need to sort of, looking back now, try and figure out how these two separate initiatives could coexist. So, and those have been my experiences, and my hopes is that after all this, we've realized we've made grocery clerks and PSWs, we've made them our essential service people, but they're the people that are earning minimum wage and earn the least amount in society, but somehow we've deemed them the essential services to take care of everybody else. So moving forward, I hope that the government and the powers that be and I can help raise some awareness about these two issues, and hopefully we can bring personal support workers, pay them and value them like an essential service and train them and understand that they are taking care of our most at-risk population. So those have been my experiences. Thank you for having me.
Thank you, Chris. We do have time for a few questions. If there are any, put them in the chat box. Wanted to see what's coming up. We have a few left over for Susie. Susie, are you still here?
Yeah.
Let me ask you one. When we were talking about the hygiene practices earlier, what are some cues implemented to help remind residents of maintaining proper hygiene?
Cues, yeah. That is one of my fortes as a speech language pathologist. Cueing, first we have to figure out what cues they respond to. So is it going to be a visual cue? I find that that's very helpful for residents with dementia and for their caregivers to help the caregivers decrease stress of repeating things over and over again. My father, who has now passed, had Lewy bodies dementia. My father-in-law has Alzheimer's, and I firsthand know the caregiver stress. So using systematic cues can really help with prompting people to do that. There are so many different varying ways you could do that. Like if it's an issue with initiation, you could use a tactile cue and start the process. And then we always want to maximize independence. So maybe start the hand washing process and see how much they can complete of their own. You might want to set a timer, have an auditory cue every couple hours, or before a meal time, you're having that timer go off as an auditory cue, or like when you hear the timer, look to our sheet for sequencing of how to wash your hands. There's so many different ways, and really everybody is such a different learner and reacts to such different procedures that's where the therapy and the skilled services come in to really figure out what the root cause is for maybe a refusal to do a certain procedure or for hand washing, and then to figure out all the different cueing systems that can be implemented at that time.
All right, thank you. There have been a lot of comments about, Chris, how much everybody appreciates your perspective and what you brought to the conversation today. Did you want to respond to that? You're muted. You're on mute if you can hear me, Chris. There you go.
There we go. Sorry, I just wanted to say thank you for the opportunity. And I have a lot of people living in the similar settings that I do, and people with disabilities, and they don't know who to speak to, and they feel like they don't have a voice. And thank you so much for everybody for listening. And I feel it's the sort of thing that when I explain to them the challenges that people face with disabilities and the barriers, especially that have been highlighted with COVID-19, people want to help and people instantly get it. And I'm extremely grateful for that. So thank you.
And one last question. If you could change one thing for people differently abled during COVID, what would it be? You mentioned PSWs as essential, but is there anything else?
I would, yeah, you can hear me still, right? Yeah.
Yep.
It's just the approach to not everybody fits in the same box, you know, for lack of a better term, in terms of like wearing masks or being able to wear gloves. And so simply asking people, you know, how can I assist you, or not automatically assuming that they're not wearing a mask because they feel that their rights have been infringed. Myself, yes, I can speak, I can breathe normally, I don't have secondary machines, but I only have half my respiratory system. So I can't easily wear a mask when I'm on public transportation or when I'm out in the community. And I feel that sometimes people are not aware of that and might just think So just being aware that there might be other situations going on with people with disabilities. You know, not everything's not what you might see on the outside.
All right. Well, thank you, Chris. And I want to thank all our panelists, Anna, Susie, and Miss Ernesta for sharing those insights. This was a great panel. I know I learned a lot. And I think we're running out of time. So I want to turn it back over to Diana to cover up any housekeeping before we leave.
Thank you guys, and thank you, Stan, for moderating such a wonderful panel. And I also, just wrapping it up with the evaluations, I did see some questions coming in today that were asking about where is the session surveys. So the session surveys are located on the session page under contents. So you can just click there, and there's just 3 questions from each session. If you're not alerted to take the session evaluations, that's where you can find it. And then the CEUs for the overall conference evaluation will be sent out on Friday on a SurveyMonkey. That's all I have for today for our session. I hope you enjoy the rest of the program today. Thank you, everybody.